Now that's a tough act to follow. Congratulations, Brian. I do have the details on the sessions that Brian Mulligan will be having for the rest of the week. So he's going to be in the 11 seminar room, and today from 11 to 12:30 will be a session on knee and ankle treatment. And then also today from 4 to 5:30 will be the session on headaches, shoulders, and tennis elbow. And then tomorrow, on Friday, same room, 11 seminar room, and he will be, from 9 to 10:30, he'll be looking at chronic back, sacroiliac, and hip. Okay, so those are the details on those added sessions. So he'll be playing here for the rest of the week. Okay, thank you, Brian. We're going to move on to the next speaker. Lorimar Moseley is a clinical research physiotherapist and NHMRC Principal Research Fellow. He has a PhD in medicine from the University of Sydney and was a Neufeld Fellow at Oxford University and is now a professor in clinical neurosciences and foundation chair in physiotherapy at the University of South Australia and Neuroscience Research Australia. So the title of his talk this morning is Expanding Our Management Approach for Patients in Pain. Please welcome Lorimar.
So I now will know what it feels like. There's a famous story of the Everly brothers having a concert and coming on after their support act, who was Jimi Hendrix. And it doesn't feel very good. So I can't see Brian, but I had so many thoughts while he was speaking. A fellow of really unexampled enthusiasm and commitment to his people. And by that I mean not just manual therapists, but I think to his species. It's just inspiring to hear more of his story. I did also notice that both he and I were receiving very impressive national awards in the 1970s. Mine was for the 9-year-old boys 70 metres running race, and his was for basically the Kiwi of the Year. I mean, absolutely astounding. A privilege to be part of that little half an hour. I'm really pleased that he didn't ask if anyone has hemorrhoids, because that would have been hard to fix. But anyway, so I'm going to try and somehow maintain the energy. This is going to be a real challenge, and I'll start off with my disclosures because they're really exciting and most relevant, I guess, for this talk. Again, royalties that I receive for books, and I receive speaker fees and course fees if you attend a course that I do. So here are some things that I hear patients say, and I have spent much of my clinical existence really intrigued by the patients that I see. Sometimes really overwhelmed, and I definitely share that really authentic excitement and privilege of being a part of a journey that someone might have from being in trouble to really living again. And I really resonated with that at the end, as Brian said, that is just an amazing feeling, isn't it, to be a part of that journey. I've also had a lot of my clinical experience thinking, what the is going on here? The stuff that I hear patients say, obviously we all hear this, it's difficult to move it, but here I think of those patients who are looking at their limb and saying, it's hard for me to get it to move. It's hard for me actually to make it do what I want it to do. My limb changes colour and goes cold, and you'll recognise this from classic conditions like complex regional pain syndrome, but also conditions that don't satisfy those criteria. Still, people look at their limb and it's changing in front of them. The pain has spread up and across my back, and when I first started to hear this as a physiotherapy student, I remember the first patient I ever saw as a student, and I'd been through a couple of years of undergraduate training where you get to practice your techniques on very beautiful, buff bodies, and you would really get excited about musculoskeletal tutorials, and you'd start to maneuver to the right area of the room for your little session of soft porn. And I always used to line up Katie Weir because she was absolutely beautiful and had very palpable vertebra. And then I got into a public hospital, and the first patient I saw, and I remember thinking, you just lie down there on your stomach, great. And it was the first person I'd seen who has no vertebra. And I remember thinking, that's a bit weird. So, you know, I did massage, and that was cool. But I remember hearing this sort of comment that what started as quite a discrete, localised pain had spread up and across their back. And what that made me think of is a why. Why does that happen? Why does it spread in that direction, if you like? And why does it cover that area? There's no nerves that cover that area. Why does that happen? The pain moves around. Raise your hand if you've had a patient, they come in for left-sided low back and leg pain, and you treat it, and they come back the next week and they say, it's fantastic, it's on the right side now. Why does that happen? Mechanistically, I think, wow, how does that occur? Feels like it doesn't belong to me anymore. Patients start to use terms like, it's got a mind of its own, or she's playing up today. I remember one person whose name was Doris, and I said, how are you, Doris? She said, I'm great, thanks. Martha's giving me the shits. I said, who's Martha? My knee. I call her Martha. She reminds me of a nun I had when I was at school, same sort of temperament. And I found myself thinking about what Doris was saying there and thinking, wow, how is that mediated to actually begin to think that this is not you, this is a separate entity with a life of its own and a personality of its own. I often get people asking me, telling me I really like your shirt. Sometimes I feel odd sensations in the limb, or sometimes I feel like my back's swollen when I know that it's not, those sort of statements. Sometimes I don't know where it is, where this limb is, or I don't know where I am, or I'm starting to run into doors. I'm starting to go and shake people's hands, and I just always get that finger grip. You know that grip when you shake someone's hand and you don't coordinate your grip very well and they grab your fingers? And you're sitting there in the shake thinking, this is just so unimpressive. And they got my fingers and they're probably reminding them of a wet fish, and I hate that. And if I've ever shaken someone's hand like that, you'll know that I redo the shake. This is advice to everyone. If you get in a finger shake, redo the shake. Because if you don't, you will forever be remembered by them as a wet fish. So how can we explain these things? And I had a fantastic dinner last night at a beautiful restaurant called Mother India. Has anyone been there while you're here? It's just an astounding restaurant, which meant that I missed out on what apparently was the gig of the century. I'd like to congratulate Roger and Alan for apparently really blowing away the crowd. Either it was you guys or it was the alcohol that apparently was in full flow. But I found myself reflecting on why I do what I do. And I think it's because of this. I really want to explain things. I really want to explore. I'm an explorer. And I really don't want to let those comments of it's got a mind of its own just go through to the keeper, which is a very sort of Commonwealth phrase, but that idea of letting them go through without thinking about them. So I find myself thinking about these things. How to explain it? And for me, I'm immediately attracted towards the brain. This is just a natural predisposition I have to think, well, that's where I'd like to look for that. So in 1 cubic centimetre of the brain, you have about 1 billion synapses. In 1 cubic centimetre, it's about the same size as maybe the end of your index finger or your thumb. There are 1 billion synapses. I reckon that's cool. And that's only the half of it. There are 1 trillion neuroglial synapses in that. Think of that number. Think of the options for connection, and I love that complexity. And this is something that I brought up on Monday, this idea of a cortical body matrix, and to take that a step further, is really a conceptual model trying to make sense of all the networks we have running from the brainstem to the thalamus to the cortex. We could call them brainstemothalamo-cortical loops, and how they behave in response to stimuli that are occurring in our personal space or in our body, and I touched on some of that stuff. But how do we make sense of this in a conceptual paradigm that we can integrate into clinical practice? And to do that, I've drawn very heavily on the researchers who are working with computer-brain interfaces in monkeys, the people who are growing neurons in petri dishes or the equivalent and watching how they connect and how they modulate and what dendrites get lost and what synapses get pruned or fostered. And on the back of all that research, and there's a lot of research on that, a lot of people with PhDs, that was a really interesting observation from Brian as well, that there are more physios with PhDs than there are doctors in Australia, doctors with PhDs in Australia. And some of the response to that, I think, was leading into this idea of a potential crisis in manual therapy. My perspective on that is that and this is I think it's an old Chinese proverb, that I think the word for crisis is the same as the word for opportunity. And I get really excited about the opportunity that arises when we have people dedicated to understanding and pursuing that. The challenge is that we all stay together on the same page and on the same boat, that we don't jump ship from each other, and I think that's really important. So if we were to conceptualise the brain as a mass of neurotags, it might look something like that. And the idea of a neurotag is just a different word for a network of neurons. And really we need to say a network of brain cells, because that network has glial cells, more glial cells than it has neurons. And it's this neuroimmune interaction that we can say, well, there's a network that over time have all developed pathways that work together. And when they are active together, they produce some sort of output. They actually produce something. And that production is the thing that still is a mystery to neuroscientists. But if we were to look slightly more closely at this bunch of neurotags and start unraveling them like you might a cadaver, if we could do that in the brain, we keep going back until we get these networks that look like this. For example, this might be, for example, a pain neurotag. And what I mean by that is a network of brain cells, neural and immune, that when they work together, the person experiences pain. So another way of conceptualizing that is this. Can you stand up if you were born in July, please? Stand up. Okay, what's the date today?
That's a really good question.
Between us, we should be able to work this out.
Today's the 7th, right?
7th? Really? 7th of July? Is it? Okay, can you raise your hand if you were born on the 7th of July? Happy birthday! Congratulations. What a way to spend your day. That's fantastic. And what's really appropriate about this is that you are a thalamus cell. You are a critical relay station in almost everything that happens to the body. And just have a look at your fellow cells in this neurotag that we might say is the pain neurotag. And let's say we've got the human lying down on their side like this, and their front's here. And if you want to have some quick neuroanatomy, this part of the brain here is called the front. This is called the back, and that's the top up there. And you're the thalamus, and you get messages from the spinal cord that might say, for example, there's danger in your back. If you turn around and look at your neurotag, and it's not until all of those other people stand up that the individual experiences pain. And let's say you have to be prepared to respond to this. Can you sit down again? Here's a real life example from our world. Let's say you reach down into the back of your car, picking up your pet kangaroo, and it gives a kick, and you tear or you tweak a bit of the annulus on the outside of the laft, the living adaptable force transducer that used to be called the intervertebral disc. Because it's got nothing to do with a disc, right? It's completely undisc-like. Just in case anyone didn't realise that it is impossible for me to line someone up in the back row there, just peel off a bit of skin and muscle and boom, shoot them with my disc. It does not do that. It's not like a watermelon seed or a lump of soap that you can slip out, right? So let's say you've got this tweak and the danger message comes up, and that activates, happy birthday, man, can you stand up? And you turn around and all other things being equal, the back pain neurotag stands up. Can you stand up? Back pain neurotag. And now the person is in pain. Oh, now they're in pain. Sorry, with early Parkinson's. Disappointing. Then the scenario keeps going and the kangaroo's out and you're sore and the kangaroo's hopping away and you look over and it's about to hop in front of a truck. And for that moment, that input's really important. And can this little group here please sit down? Now there is no back pain. There is no back pain whatsoever. There is concern for Skippy. And then Skippy makes it clear and you think that's fortunate, and the inhibitory control changes and up you go again. And in that second, now there is back pain. Because it's this group of brain cells that are responsible for producing it. And that's how we conceptualise the best of what we understand. Can you sit down again, please? I hope that makes sense. This might be an example that you have brain cells that do lots of different things, and you can see here some classic brain areas that we know are often active when someone is in pain. And one of the really important concepts in understanding neural networks or neurotags is that every member of a neurotag has multiple neurotags. So they're multitasking cells. For example, that cell there might be involved in this neurotag. It might be involved in that neurotag. It might be involved in that neurotag. And that cell has multiple functions. Let's say this was a cell in secondary sensory cortex and was involved in the production of back pain. It's more than likely that it will also be involved in the processing and experience of touch, of tactile performance. It's likely that it will also be involved in proprioceptive representations. Where are you at this moment in time? Now, for someone like me, as you will remember, and you'll be pleased to know if anyone came, well, it's clearly at least some of you came on Monday. There's probably an overlap of at least a few of you. I gave a demonstration in order to win a bet and get a copy of Miles Davis' vinyl album that is very hard to get, and you'll be pleased to know that the person has seen this on Twitter, and I am now the owner of a very rare Miles Davis record. So thank you for whoever put it on Twitter. I appreciate that. But you'll know from that I have pretty precise neurotags that give me the pelvic tilt. And it would be fair to say that the neurons that are involved in representing those parts of my body are also involved in making them hurt. I hope that's intuitively sensible. So what governs how neural networks work? And ultimately it comes down to these principles of influence and probability. And this idea of influence is one that we can easily put into our lexicon. How influential is this input? And what I mean by that is how likely is that input to change a future input and to change activation of another neurotag. And I'll explain what I mean by that. The most influential neural networks in the brain have two characteristics. One is that they have a lot of cells in them, a lot of brain cells, neural and immune cells, and nociception is a powerful driver of networks in the brain. So we would argue that nociceptive neural networks or nociceptive neurotags are high mass. There's a lot of cells involved. And you can see that on brain scans and you can see that in animal studies. These networks are almost hardwired. In fact, nociceptive networks we would argue are hardwired. And I'm nervous about that wiredness because of all the glia, and they don't work like wires, they work more like conductive pads or gels if you like. But the idea of it being very old structures evolutionarily and development-wise, and it's a high-mass structure. So if you get a noxious stimulus and that manages to send a noxious stimulus to the brain, so a message to the brain, danger message, you're likely to activate a big, fat neurotag. And that is going to be very influential on what you end up feeling. So there's a nice relationship between nociceptive input and pain. Remembering that nociceptive input is not enough and it's not necessary for pain, it's just highly influential. The other thing is the probability that the target neuron and therefore its neurotag will fire compared to the neurons around it. And one way of conceptualizing this is as though we are precise in our neural networks. They are high precision networks, and that depends on inhibition of unwanted brain cell activity. We call that intracortical, intra-brain inhibition. So there's a whole range of examples of changes in influence disrupting this idea of the cortical body matrix. And there's a large body of research on this, and I'll just give you a snapshot of a few little things. So these are data that we collected from people with complex regional pain syndrome. And if you're not quite familiar with that, it used to be called reflex sympathetic dystrophy. It's the sort of patient where if they turn up in a florid CRPS state, it's intimidating for everyone, including you as the clinician, and these people are in trouble. So 1 in 5 people with a greater than 6-month diagnosis of CRPS have planned or attempted suicide to get out of their pain and disruption. These people are in severe trouble, and their cortical body matrix is highly disturbed. And in this particular study, we look at the influence of a tactile input from their good hand compared to a tactile input from their bad hand. We deliver those stimuli at slightly different times, and the task is that that individual tells us which stimulus occurred first. So for example, I'll show you what I mean. So birthday man, I'd like you to participate in this. Would you be able to stand up, please? Do you have another name? Alistair. So Alistair, we might be delivering tactile stimuli to Alistair's hands, and to represent that, I'm going to click my fingers. All right, so that would be your left and your right. Is that okay? Can you close your eyes and tell me which one occurred first? You can point left. Well done. Okay, keep your eyes closed. Okay, so Alistair's starting to make mistakes. It's clearly an old birthday. But can you understand that? So sometimes we do, and Alistair would say left. Well done. Or we might do, and Alistair would say right. Thanks, Alistair, you can sit down. And we do that over and over, and we just change the separation between those stimuli. So sometimes it feels like this, and other times it feels like this. And it's more difficult when they're close. Nod if you understand the paradigm. Lots of nods, great, cool. So when we do that with people with pathological hand pain on one side, we have to stimulate the bad side before the good side for them to think we stimulated them together. So another way of saying that is that the tactile input from their good hand is more influential on sensation, on experience, than the tactile input from their bad hand. And this finding in people after stroke would be considered evidence for unilateral spatial neglect, if you got your bearings on that. So we conclude from that tactile stimuli from the healthy hand are more influential, and therefore they're felt first. They trigger an output more quickly because they're more influential. But the bottom picture there shows that when they cross their hands over and we repeat the experiment, the relationship is reversed. So it's actually not about stimuli from their healthy hand, it's about stimuli from the healthy side of space, because when we put their bad hand in the healthy side of space, now the brain, this one has more influence. The bad hand has more influence in the good side of space. And the way that we interpret that is that this is a spatially defined extra influence. So to try and make sense of that, we can really only conclude that either the neurotags that represent one side of space have a greater mass, there's more neurons in them, or they are more precise, but we think it's about mass. So a more influential neurotag set representing left-hand side of space means that tactile stimuli from left-hand side of space are more influential. I hope that makes sense. If it doesn't, I'll try it again with these data. So these are data from people we managed to recruit a whole lot of extremely fit, agile-looking people and draw black lines across their back. and we only accepted participants who had inordinately small bottoms. That's a really small bottom, right? Like, I don't even know if, like, imagine if he had hemorrhoids. Anyway, so we've got people like this with unilateral back pain. That might be the area of his unilateral back pain, and he's had it for a long time. He doesn't change sides. It sits there on that side of his body. He might or might not have leg pain. That wasn't a criterion for this study. And then we put little vibrators on the skin over the back, and we replicate that experiment, and we say which one occurred first. And then in the control experiment, and I'll direct you there with the laser pointer. Okay, in control experiments, we get them to hold the vibrators in their hands and put their hands near their back. Right, you've got the bearings there, so now they hold the vibrators and they hold their hands right next to the back without touching it. And we do exactly the same task. Which occurred first? In another control experiment, so there are 3 experiments in this paper. In another experiment, we cut their arms off and then put their hands in mid-air in front of them, holding one vibrator in front on the painful side and one at the back on the painful side. And then we did the same thing on the other side. So I hope that makes sense. And here are the data. So I'll talk you through this. These are the graphs that you get out, and I've just blown up this. This is when the vibrators are on the lower back. And I've just blown this up so that you can see the response is shifted to the right from 50%. And that tells us convincingly that the tactile stimulus from the painful side of their back is less influential than an identical stimulus on the other side of their back. That's what that shows. This is when they hold the vibrators in their hands and put their hands behind their back, and we replicate that exactly. So this problem is not about the stimulus getting from the back to the brain, because when we do it with the hands, there's nothing wrong with their upper limb, either upper limb. But when we hold the hands in the same place, the influence is replicated. So we conclude this is not over-influence of one side of the back compared to the other. This is over-influence of one area of space compared to the other. It's a spatially defined problem. These are data from controls, and I could put up data from the other experiments that just tell exactly the same story, replicating this spatial. There's an area just around that low back and the top of their bottom, but anything that occurs in that space is not very influential on experience when there's a competitor. And some of the things that we do now, people with really chronic low back and sciatic pain, we can video, and then in order to show them later, that we have a little clicking device, makes a sound, that we just say, tell me whenever you hear the device, and we click it around all over the place, and if we click it just next to that part of their back that hurts, the probability of them detecting it is about half as much as it is for everywhere else. As though the brain there's no influence of any stimulus occurring inside that space. And that's a really powerful educational tool that we can show the video, and they see on the video that we've clicked the clicker and they didn't hear it because it was in that area of space. So this is one of the opportunities that I think is arising from research into people with pain, to suggest there's a spatial signature that seems to be happening with people with chronic pain about influence. These are data that we published this year in a journal called the Annals of Neurology, where we are interested in whether we could replicate signs of spatial neglect, which looks at a line bisection task, in people with chronic unilateral limb pain, because we're quite convinced that this spatial influence is messing with their ability to control their body. And we would predict that that would reduce the connection they have with this body part. It would make more likely statements like, it feels like I don't own it, I'm not very well connected to it, I don't know where it is, it would support those things. It would also imply that maybe we should go back to some of the principles that have become less cool of crossing the midline for some of our interventions. Possibly, that's the speculative bit. In this particular study, we got people, they're normal on line bisection tasks. They perform completely normally. So there's not a classic spatial problem going on. But as soon as the task involves a body part, the situation changes. So the top picture you can see here is when we get them to put their hand in this orientation and ask them to find the middle of their hand and just mark it with a pen. When they do that, they perform completely normally. That's on the midline there. But if they turn their hand around like in this orientation and now they mark the middle of their hand, the location they mark is shifted towards the affected side like we would see in neglect. And the effect size is 3, like it's a massive effect. So having a bodily representation collaborating with a spatial representation. So having a bodily neurotag collaborating with a spatial neurotag, there is clear spatially directed distortions. Now we think, if we speculate a bit, is it any wonder that these people, if it's elsewhere in their body, might start to run into doors? Because to go through a doorway, you need to integrate your bodily neurotags with your spatial data. And if there is a spatial influence, then you won't approach the door in the right place. That would be the speculation. These are data that have been collected over a decade. There's a lot of subjects in this, and a lot of them have participated in other experiments. A lot of them have not, so there's about 1,000 participants in this data set. And we know, and we've known for over a decade, that people with pathological hand pain, if you show them a picture of a hand and the task is to recognise, is this hand a left hand or a right hand? This is a task that's variously known as left-right judgments or laterality recognition. Implicit motor imagery. If you do that, it takes people longer to recognise it if it shows their affected hand. That's a really well-established finding, and that effect size is very large, particularly in people with complex regional pain syndrome. This is a reaction time test. It's not an accuracy test, it's a reaction time test. Then what we've looked at in this big data set is, does it matter whether that picture is placed on the left or the right-hand side of the monitor, the screen in front of them? And yes, it does. So what we see here is this is when the tasks are appearing on the healthy side of the monitor, and you can see here's a delay. The healthy side is recognised in about 1.1 seconds as a rule. When the picture is displayed on the other side of the monitor, there's also an effect on the healthy hand. So, and the healthy hand doesn't seem to perform that much differently to the unhealthy hand. So what these data show us is that there is both a hand-specific delay and a space-specific delay on the left hand, on the affected side. And all this does really is corroborates this idea of bodily specific spatial distortions in the cortical body matrix. But again, the step towards a clinical implication is a pretty small step, I think. And now we're testing treatments that target space as well as the body. This does not happen if the pictures and the task do not involve bodily parts. So if they're shapes or they're letters, there's no effect of this. So it seems to depend entirely on the integration of a space neurotag and a bodily neurotag. And we interpret this as being about different influence of different areas of space. We interpret these data as showing different influence of different areas of space. What about imprecision? So what about a lack of intracortical inhibition? How might that manifest in our people with pain? And here's some examples of that data. Again, this is just plucked out of a wider body of literature that's freely available to read in reviews. This is a study where we have people with an affected hand and a healthy hand, and here they're doing a task where they need to do repeated circles with their affected hand or their healthy hand. And when they do it, that increases their pain here. In this sample, maybe it doesn't. The p-value is short of the magic 95%. We could interpret this two ways, that we are 92% sure that they increase in pain, or we need a few more participants, which actually we've now got. And there's a significant increase in pain when people perform 20 circles trying to keep them consistent with their affected hand. On the other side of this, you can see what happens when they do the task, but their hands they're doing it on the other side of space. So this circle here is when they use their good hand on the affected side of space, and hopefully you can see this is not as good as that. And the group data, this is just representative. The group data support what I'm showing you here with statistical significance. Hopefully you can see they're not as good, and the circle's a bit bigger. And that's really interesting for the way that motor control and proprioceptive feedback work together. It's about limiting outputs, not about extending them. So if we have a loss of precision, one of the manifestations will be that the commands let you go too far before you pull back in constraints. And actually a lot of our neural representations work according to that principle, as though we've got a rope onto someone and we're keeping them from going too far. To make sense of that, sensorily, remember the last time you went to the dentist and you had a local anaesthetic injection? I remember going to a dentist who was a very dodgy looking fellow. In my view, he was dodgy because he was just too well dressed to be a dentist. He had his Mercedes-Benz in the car park and he was only young, and I thought, you are clearly an unethical operator. Clearly I've got a few biases, right, that I have to deal with. I've got a few repressed issues or something. But he said to me, oh, you need a filling there, can you see it? And there was no need for a filling, I was sure. Until he said, no, you'd really need that filling. I really need to give you a filling. And he had this sort of hypnotic thing. Yeah, you will get the filling. Okay, it's a bit hard though when you, like that. Gave me a filling, and I came out and I had this big fat swollen lip. Huge lip and tongue. And I got home and I said to the beautiful Anna, look at what this bastard did to my lip. And she looked at me really closely and she said, which lip? Which lip? Are you blind? Look at the size of my fucking lip. Now my lip wasn't big, right? You recognise this feeling? It wasn't big, but it felt really big. And we make sense of that because of a loss of precision in the neuro tags that give you a feeling of where your body ends. That's how we interpret that. And you can get that with local anaesthetic, you can get it other ways, including you can get it with repeated noxious stimulation. This is the motor equivalent of that. So there is clearly a side-specific effect, and we would interpret this as imprecision. We're losing precision within the neuro tags that integrate space and motor output. And hopefully you can see it's a small step. We haven't tested this yet. We're testing it. It's a small step to suggest that maybe there's merit in doing motor tasks in the healthy side of space when you're learning how to do motor tasks, because you recruit the precision of the spatial maps that you don't get in the normal space that this body part is involved. What about in disrupted motor imagery? So there's a range of studies that we've done here. Here we might show this photograph and ask, is this person's head turned to the left or the right? Is this person's trunk turned to the left or the right? And it becomes very difficult when they're upside down. Is this a left or a right foot? Is this a left or a right hand? And many of you will be familiar with these sorts of tasks. And it's the loss of accuracy in this task that we attribute to loss of precision. So just reminding you, a change in reaction time we attribute to a change in influence. A loss of accuracy we attribute to a loss of precision in the brain. So people with chronic neck pain are less accurate at this task than people without chronic neck pain, but they perform normally at all the other body parts. And this pattern is replicated across body parts, chronic pain states. So CRPS, where it's probably a bit more profound. So now we would argue these people have a loss of influence and reduced precision in their neuro tags. Neck pain, back pain, foot pain, and NEO-A, phantom limb pain, carpal tunnel syndrome from Michelle Copiter's work. Nico has done a lot of work on amputees. So what's going on? Can we actually look at this with imaging? So this was a study out of one of my students' PhD. Her name's Flavia Di Pietro. She won the International Association for the Study of Pain student award at the last World Congress. She's an outstanding young researcher. And she really single-handedly took on the assumptions that we have that areas of the brain that are in pain have a shrunken representation. Because that doesn't make a lot of sense, actually, based on the basic science work. So Flavia employed a new technology to look at this, and this slide tells the story of her finding. The paper is really quite complex. It's in human brain mapping, but I'll tell you the story. You can hopefully see the blue dot and the red dot here. This is just an example from one person. This is the healthy hand of someone with CRPS. This is the affected hand of someone with CRPS. And this picture has been studied many times, 8 or 9 times, but only 1 or 2 of those studies has compared it to a control group. And they didn't do statistics on it, and Flavia, in her meta-analysis, showed this. What she shows here is that, yeah, it certainly looks like it's smaller than that one, but when you compare it to controls, this is the dominant hand of controls, that's similar, and this is the group data. So this comparison here shows that the proportion of S1's primary somatosensory real estate dedicated to the painful area doesn't seem to shrink compared to controls. So this is a new understanding. I imagine that some of you would have read the work. I've published work saying it's shrunk. But when Flavia said, has it really? I love that phrase for a scientist. Is that true? Is it really happening? Let's really find out. Then it seems to be that it's not shrinking. So what's happening? So this is work from Audrey Wang, who's doing a PhD, just about to submit, although she had the poor planning of having a couple of children during her PhD program, and that always hampers work productivity. I suggest that she puts the children away until she's finished her PhD, but she didn't seem very responsive to that advice. Audrey's done some beautiful work looking at individual representations of specific fingers in the hand. So this is work informed by visual perceptive field data. It's done in collaboration with the fellow I mentioned on Monday, Giandomenico Alessandro Magnifico Fantastico Perfetto Ianetti, and Flavia Superbo Bella Mancini, who's in his lab, who's really done most of the work on that. And this is what it yields. So these are just some examples from patients and controls, and hopefully you can see it looks like nothing at all. But if we look at it a bit more closely, I just want you to look at, this is the healthy hand of someone, and hopefully you can see this is digit 5, this is digit 4, this is digit 3, and this is digit 2, and there's a beautiful sequential activation in primary sensory cortex. They're represented right next to each other, as you would predict, I guess, based on animal studies. But this is really brand new data. It's not published yet, so don't go and put photos of this anywhere, please. It's really beautiful data. This is a CRPS hand. So here's digit 5, here's digit 4, here's digit 2, and we can't find there anywhere a distinct representation of digit 3 or digit 1. So in fact, we only did 2, 3, 4, 5. So digit 3, we can't find it. We wonder if that might be it there, but hopefully you can see it's not a beautiful representation. The total real estate is the same, but there's weird maps. They're all disorganized, and here's just a way so you can see it clearly. Here's an example, digit 5, 4, 3, and 2 in the healthy hand or healthy controls, and this is the CRPS hand. So digit 5, digit 4, digit 3 in 2 locations, digit 2 in 2 locations. And here's an equally distorted representation. So think to yourself, so what happens when this person tries to do a single finger movement? There is a high risk that they'll activate neurons that move other fingers as well. And now they have to try and stop that. So we end up in a dystonic type presentation. What about percept? These are data. The left-hand picture there is from Jenny Lewis and Candy McCabe, who do some really interesting work in Bath and now in Bristol on complex regional pain syndrome and distorted feelings of your body. These are drawings by patients. This is complex regional pain syndrome. This is someone with osteoarthritic hip pain, osteoarthritic or rheumatoid arthritis, I think, wrist pain. And these people are drawing what their body feels like. What does it feel like? It's a really interesting question to ask your patients. Does it feel like it's the right size and the right shape? Or more appropriately, tell me what the size and shape feels like. And once I started to do that about a decade ago, I'd have some really beautiful aha moments, you know, of people saying, yeah, it feels weird, but I haven't wanted to say that because I have no paradigm to explain that. So it's a liberating experience for patients to be able to admit that, and we often get people drawing as best they can what it feels like. So we explain that finding there by imprecision, a loss of inhibitory control among neurons, just like we see with the local anaesthetic. What about tactile acuity? Well, we now know from a bunch of studies, and I'm presenting now data from Mark Catley's lovely meta-analysis of this, but there's a lot of original articles that tell this story. Tactile acuity is worse in chronic pain, even accounting for any loss of sensory detection or transmission. So tactile acuity looks at the precision of neurotags, really involving primary sensory cortex as a rule. And here are data from chronic back pain patients. So looking at the wider body of data, and there's a reasonably limited cohort here, but this is all the published data. But on the basis of that we can now be 90% sure that tactile acuity is abnormal if their 2-point discrimination threshold is more than 6 centimetres on their back. So we've got a clear clinical implication. If 2-point discrimination threshold is less than that, we don't have enough measurement accuracy to be sure that there's some sort of problem. Maybe tactile acuity is worse on one side than it is on the other. If that's the case, we need to have a difference between sides of 6 millimetres to really conclude there might be a difference. CRPS on the hand, we only need a small difference to conclude, yes, there's a tactile acuity problem here. And in knee pain, if we've got a tactile acuity of greater than 4 centimetres, greater than 40 millimetres, we can conclude, yes, tactile acuity is disrupted here. And you might think, so what? I mean, what does that mean? How does that change our practice? Well, now we know that it can change your practice in a way that can give some clinical results quickly that you might not have got before. So how does this happen? How does imprecision occur in the brain? And the probable mechanism, I guess this is the prevailing theory, we're not sure, but we think this is the explanation for imprecision within the cortical body matrix. And it comes down to these things that I mentioned on Monday, the immune cells that are always working with synapses, giving them a balance between pro-inflammatory input and anti-inflammatory input. And that balance determines two things, the efficacy of that synapse and the degree of precision or probability related to that synapse. So don't worry heaps about that, just know that these are the cells that we think are important, the microglia and the astrocytes, possibly oligodendrocytes, another type of immune cell. But this is what it really manifests as, and this is the principle that we can take away. So on the left, we might have the normal state associated with activation of a neurotag. So that input from one member of the neurotag has a very high probability of exciting that next neuron, and a very low probability of exciting the others. So, can the back pain neurotag stand up, please, again? Remember who you were, stand up. Okay, so I'm going to just pick someone, and this, Ian, how are you? Okay, would you be able to put the lights on on the floor a bit more? So Ian, can everyone else sit down? And Ian, I'd like you to put your hand up and say, hello, I am Ian.
Hello, I'm Ian.
I am a cell in the amygdala. Okay, actually, if you're a cell in the amygdala, I'd like you to say, hello, I'm Ian, I'm a cell in the amygdala, fuck off! No, you don't have to say that. Sorry, but you know the amygdala is sort of associated with anger. It's got a lot of things. So let's say you can put your hand down again. It looks like you're about to swear on the Bible, and I will contribute to this neurotag, only this neurotag and nothing but this neurotag, so help me God. So let's say that Ian is in a normal state here, so when the excitement comes in, can you just sit down for a moment? When the excitement comes in, there's a very high probability that Ian stands up. And that's good, that's what we want. All right, and now you can sit down again. Now, if you could spit on Ian without moving, I want you to stand up if Ian stands up. All right, so now the excitement comes in, it goes towards Ian, but we're in a local inflammatory response, which we know occurs. And now there's a high probability of a range of brain cells operating. So up you go, Ian, and if you're within spitting distance of Ian, come on, you guys can spit. Whoa, look how far you can spit. Wow. So, sorry, stay up, that's great. Can you stay up? So this is what might happen. Or we might actually get not Ian, but we get someone else, because the probability levels are so similar, and we attribute that to inflammation. And that has profound consequences if any of those brain cells then recruit their own neurotags. And now we're in a situation where the output is a bit more variable. Or we have several outputs activated at the same time. I'll show you what I mean by that. Remember this is the idea of multitasking brain cells. If that brain cell was in primary sensory cortex, remember that it's activated in a few things. Imprecision around here would explain loss of tactile acuity. Imprecision in primary sensory cortex, which we now attribute, or secondary sensory cortex as well, which we attribute to a local inflammatory response in the brain, would manifest as reduced tactile acuity. It's impossible for us to conclude that's the case in a given patient, because we can't record from their neurons in their brain. There's no mechanism to get better resolution than several 100,000 brain cells, even in an imaging study. Let's say that this imprecision was occurring in premotor or posterior parietal cortex, so integration of a lot of different sensory inputs, planning of motor outputs. Imprecision happens in either of those places, or indeed in both, then that would manifest as poor accuracy in this task, because you've got different levels of probability of firing different neurotags. And if the difference between similar neurotags is small, then we've got inaccuracy problems. And the implications of this work may be more profound than we thought they were, and these data are coming out of a PhD by Kerwin Talbot, who's a podiatrist, who's working with Johan Vlaen and myself towards a model that we call the imprecision hypothesis. This was the paper proposing that model, published in Pain last year, I think. What this graph shows you is a conditioning paradigm where people need to learn what movement is likely to trigger pain. So people need to learn through classical conditioning what movement is likely to trigger pain. So if we take this into the clinic, we might say people need to learn which forward bending movement is the problem, compared to similar ones that may not be as much of a problem. In this experiment, hopefully you can see that there's a significant difference here. And this shows that if people don't learn the precise movement that is painful, they predict pain on safe movements. They predict pain on movements that would not evoke pain. This has important implications for behaviour, but it also has important implications for feedback loops. And there's a very reasonable learning paradigm that would suggest that if we instate this, then ultimately these movements will become painful from a learning perspective and a neurotag influence. Here's a study by Dan Harvey, who I mentioned on Monday, and I had the pleasure to meet one of Dan's current laboratory colleagues this morning. Hello, Scott, shouting out to you. That was great to meet you. In Dan's study, we asked the question, well, does the precision with which you can encode space change anything? And in short, it does. So we compared exactly the same collection of electrodes on the back or on the hand. On the back, it's, the somatosensory system is less precise than it is on the hand. And the differences that you can see emerging here tell us that dangerous versus safe stimuli are learnt when non-nociceptive encoding is precise, but not when it is imprecise. So this has implications again for our management, that we need to take special care and possibly recruit other sensory modalities. If anyone was at Sanika Don's talk earlier this week, I think it might have been Monday afternoon, talking about the use of vision Well, we can use vision, which is a very precise sense, to instill learning about what is truly dangerous and what is less dangerous. So what are the implications for patient care? So this is the end bit, I guess, of my objective. And I would say that the implications are that we can start to be creative about changing influence and precision in patients. We want to reduce the influence of nociceptive or other neurotags, and we want to increase the precision so that we get less spread, a greater probability of the output that we predict on that. And I think some of this is relevant to the clinical manifestation of centralisation of symptoms. I think that's about probability more than it's about anything else. So one way that we've been doing that now for 15 years is through motor imagery and graded motor imagery, starting off with this task, which is the left-right judgment task. And we know that once you are practiced at that task, when you perform a left-right judgment, your premotor neurons project to primary motor cortex cells and they excite them a little bit. Not enough to fire them, a little bit. And that process of excitement, we know from animal studies, improves intracortical inhibition. So we're reinstating the normal probability curves of firing the right neurons. So if we keep doing it, we know from monkey studies that we will go back to a more normal probability curve. We can do it in the sensory system, so tactile discrimination training is now, we've been doing that for over a decade. These are data from the first study that looked at that, where all we did was we got people to put their hand out of sight. We gave them a photograph of their hand or a picture with 5 locations on it, and then we gave them stimuli to the hand and they just had to tell us which stimulus had been used. Okay, that's location 2, if you like. This is when we don't, this period here is when they don't have to answer the question, this period is when they do have to answer the question, and this is a 3-month follow-up. So we get a clinically important shift in symptoms when we reinstate precision in the primary sensory cortex. We can enhance that further by using vision, and we know that the visual cells, there are bimodal cells in the front of the brain and in the back of the brain that have a convergence at primary sensory cortex, so we can use vision to improve precision, point I made earlier. But you don't have to do tactile discrimination training. In fact, we know that this principle applies to any stimulus-oriented task where there is a behavioural requirement to differentiate one stimulus from another. That's it. And I think of a classic Maitland assessment. Is this your pain? Is that your pain? Is this your pain? Is that your pain? And that is a behavioural task that will be working on precision. And for me, it may just reflect my bad manual skills, but I used to find that possibly my most effective treatment using those techniques was the assessment. I don't know if anyone else would relate to that. But we get these changes when I haven't had time to do anything. We get these changes in function, and I never understood that, and this is one possible mechanism for that. So how do we identify and depower influential neurotags? And this is underpinning a model that we've just tested, which has good clinical outcomes in people with chronic dodgy pain. It's based around the idea of a protectometer. This is a drawing of cerebella, which is the focus of that is to challenge concepts that people hold about their health and their body without challenging them. And if you were to look more closely at cerebella, you would see things like this on her. This is one that I feel particularly passionate about. Discs never slip, ever. I think that's important. But also, the kisses of time are rarely dangerous. X-rays and scans, we grow like trees, which is planting the seed for people to say, what's this talking about? We're doing a study at the moment where we're changing radiology reports from reading degenerative changes or degeneration to reading adaptations to load. That's the only difference, and they're the same thing in most of those scans. This is the protectometer, and ultimately we want people to think about all of the influences on their internal protection meter, the ones that promote danger and the ones that promote safety, and we get people to walk through everything that we know from the literature modulates pain. And what that means is everything relevant to the individual can modulate pain. And it's all about that compulsion to protect, which I spoke about, hopefully you'll remember, from Monday. We get people to walk through that and fill out post-it notes and think of all the things that they find dangerous. And hopefully you can see, just for examples here, the surgeon's office. That might be adding to the influence of you need to protect, this is dangerous. It might be a sim for someone else, so it's a dim for this person. It might be evidence of safety in me for someone else. Dancing class with my bestie might be a sim with my best friend, for example. This is just so in case you couldn't see the last one. And then how do we integrate this into classic graded exposure? Well, this is a process that you'd all be familiar with certainly with physical upgrading. And now we incorporate the true biopsychosociality of pain into this idea by looking at sims that might be environmental sims, social sims, cognitive sims, mood, state of the body, drugs that you might be taking, and we gradually expose people across those things. So if we were to look more closely at that, we might upgrade one day by moving to a more threatening environment. The next day we might add a social threat. Then we might decrease the environmental and social threats and then add the mechanical load that we couldn't add previously. But all of these things are promoting adaptation in your system, in your neuromatrix, if you like. We might add a cognitive threat, get people to do the same load, but now they've got a cognitive threat going on. Maybe that's an arithmetic task. Maybe it's recounting your first kiss. It's a cognitive social threat. Here we might say, okay, let's go back on the cognitive threat and we'll add a systemic threat. Do it when you're really tired. So we've got an extra dim going on. And then a question that often comes up is, what do you do if you flare up? And we have a very formal response to that, which is just halve the increments of progression. Go back to what you did and halve the increments. Okay, so sorry, I'm going to go through this and get to my last slide because I think it's interesting. This is work from Tasha Stanton. This is something that we're playing with now and seems to be helpful in people with chronic pain, where we use visual input and tactile input. So the hand is in a device called the Mirage, which was invented by Roger Newport, pulling on their finger, and they get the illusion that they're opening up the joints or stretching the finger. And this is a pain-relieving technique. That data shows it's pain-relieving. This is the knee version, which is people with osteoarthritic knees love this. They seem to anyway, this is what I've been told. And you get a very distinct illusion that you're actually stretching the joint space. So we're messing with influence and precision with that. This is my research group. I stuffed up my diary when I did all the plans to come here thinking that this conference finished today, not tomorrow. So I'm committed to leaving this afternoon, but I'd like to say in front of you all what an impressive meeting this is, what a privilege it is to be endorsed by you people as someone who's I'm not in the hood, but I really feel endorsed by the people I've met. I'm very grateful for your feedback, and I guess I just want to encourage everyone, because I can always hear this at physio and manual therapy meetings. I just want to encourage you all to commit and intentionally maintain positive relationships between the scientists and the clinicians, because this is where the opportunity lies, and I think this is where the revolutions will occur. So I'd like to congratulate you all, and I'd like to say thank you very much for having me at your meeting. Thank you. Thanks. Before I go down, thank you.
Thank you, Laurie, for a wonderful presentation. Unfortunately, we seem to be out of time for questions, but I'm sure he'll hang around up front if people have specific questions. So enjoy the coffee break.